I want to take this opportunity to thank our representatives that have come from our alumni and partner hospitals. It's lovely to see a lot of people here again today. So this is a very popular event over the years, as we've seen. Through Nursing Week, it's a busy time for everybody, but normally we have a panel of this nature. And this year we're particularly pleased with the panel that we're having this evening. And it's going to be a little different than what we're used to when we think of data and using data. So the focus for this evening is data-driven decision-making, how you can use data to inform policy, how you can use data to inform practice, and how data can be used from a patient care perspective. So we're going to hear from three different individuals this evening. We'll start off with Dr. Walter Sermius. He's in the center. Dr. Sermius, I'll just tell you a little bit about him. He's the Francis Bloomberg International Distinguished Visiting Professor with us this year, Professor of Healthcare Management at the Leuven Institute of Healthcare Policy, University of Leuven in Belgium, and a member of the Strategic Advisory Committee of the European Health Management Association. He'll be talking a little bit about international issues around data and digital health, a little bit of the European context for the use of data to derive larger, more administrative-focused decision-making. Then we're going to hear from Lynn Nagel on our right. She's an assistant professor here at the faculty, and most of us in nursing know Lynn really, really well, known as a pioneer in nursing informatics, really globally, but especially here in Canada, has had really known in Canada for developing the field, really consults a lot on the education and implementation of informatics in nursing. And so she's going to discuss data and informatics from the more administrative nursing leadership, healthcare leadership, and Canadian context. And then we're changing it up a little bit with Dr. Kelly Metcalf, who's a professor here at the faculty. And her focus, she has the Bloomberg Professorship in Cancer Genetics at this time. And a lot of you will have seen or heard of Kelly from her really internationally known program for research on BRCA1 and BRCA2 genetics in breast cancer research in Canada and internationally. And she's really led a lot of the changes in how patients actually can use data to drive or make decisions. And so we asked Kelly to talk to us a little bit this evening, added her to this panel, to talk a little bit about how researchers can develop a database that can actually be used to inform patient decision making. And all of us that are working both in healthcare organizations and here within faculties or other faculties know how important patient-oriented research is and patient engagement in healthcare is. So we'll hear from everybody in that order this evening, and that's kind of the focus of the discussion. They're not going to be long talks. They're usually about 8 to 10 minutes each. And then we'll have time at the end to engage with questions and a little bit, I think, before 7 probably, okay? Anyway, thank you very much for coming this evening and welcome to the panel.
Good afternoon. My name is Walter Sermius, as the chair has already announced, and I have the honor to start the panel. And so the topic I will talk, it's more about the policy topic. So I'm involved in European work. I was coordinator of a big European project in making the connection between nurse staffing and outcome, patient outcome, what is quite important. I won't go into the details, but quite important work. I'm now more involved in health workforce issues across Europe, so I will mainly tackle that type of issues. And just to start with the policy question, you see over here a quote from Deming, and it's he's a quality guru, and I think it's important. I think it's probably important for this session. Without data, you're just a person with another opinion, and so data are crucial. So when we are using and talking about policy making or talking about decision making in general, I think data are quite crucial to have, as well clinical as well managerial. And I think the challenges are quite big. I put some challenges over here, what we see around the world since a few years. I turn a little bit so I can peek into my slides. But the first thing is a report from the Institute of Medicine. So the Institute of Medicine produced a report to Aris Human, I think in 99, 2000, to mainly focus on quality problems. And a few years later, it's about this report, Crossing the Quality Chasm. They were saying quality is a little bit more than just patient safety. They are focusing on quality, patient safety. They also focus on efficiency. They also focus on effectiveness, equity, patient-centeredness, and so on. And so their main observation, and I think it didn't change during the last 15 years, is that healthcare still have to improve. And when we are talking about improving, there are some data. So if you compare to other industries like airline industry, it's not becoming 2 times better. It's becoming 100 times, 1,000 times better. That's the challenge. And so really, we really need to have some data to improve. I saw a paper last week in the BMJ who was saying that medical errors is a 3rd leading cause of death in the country, United States, if we're talking about. And so there are no data about that. The data, what we are using are data about classification of diseases, of classifications of deaths using ICD-9 and ICD-10 codes. But there is no code for medical error. There is no code for adverse event. People are dying from myocardial infarction or from sepsis. These are the reasons people die. But they are not dying because there is a medical error. So if you take this kind of terminology into account, it would be the 3rd leading cause of death. We did similar calculations now in Belgium. I see similar figures probably in Canada. I think it's serious. So we have to take it quite serious to talk about patient safety and quality of care. The second thing is that, so the Institute of Healthcare Improvement in Boston is taking this challenge of poor quality to really make the aims. And the aims is to increase the experience of patients on a subjective way, objective way, so really working on the quality of care. At the same time, not looking from an organization's perspective to health, but more from a population perspective. It's really taking care of the health of people. And so it means that probably a shift to prevention, probably a shift to lifestyles, probably a shift to taking care of people instead of waiting until they are sick and we can care for them in a hospital or something like that. So it's really making a broader perspective. And the 3rd element is probably the cost of care. Cost of care, I think what we all know is that healthcare will be quite expensive and will be more expensive in the future. But what we see is that when we are taking quality issues into account, what we expect of what we see is that about 25 to 30% of our cost is related to not performing well, quality issues, waste, things we don't have to do, overuse, these kind of issues. So these are the serious issues. And so to do that, to really keep our health systems sustainable, we need workforce. We need people to do that. We need doctors, nurses, occupational therapists, dietitians, all these important people for healthcare. And so what we are afraid is that the workforce will lead into a shortage in the near future. Near future is 2020, 2025, 2030. What we see already at this moment in time is that 1 out of 10 people are working in healthcare already, and probably we will need more people. And what we will see is that also the workforce is aging. Not only your patients are aging, but also our workforce is aging. And so we see some need for replacement, we see some need for taking care of people, and what we are afraid is that we will lack about 15% of people to take care for our people. So it's really about the sustainability of health systems. It's really taking these health workforce quite seriously and to really develop strategies on the workforce. So these are the challenges. Of course, we are talking about these challenges, and so we are talking about the future, and we don't know the future. So we have a project now in Europe about, it's a joint action on health workforce planning and forecasting. You can imagine that forecasting is the most difficult thing you can do. And so the most difficult thing is about forecasting is forecasting the future. So forecasting the past, that's easy. But forecasting the future is quite difficult, quite hard to do. So we don't know what is happening. Some people are saying, in the future, health needs will decrease because people are more healthy and other lifestyles and so on, and we go into self-management and all this kind of thing. Some people are saying, no, it will be the opposite way. It will be increasing because we have older people and new diseases are coming, and people are aging and are more dependent. And so there are so many unknown factors. But there are a few things we certainly know to take care of healthcare. One is giving the challenges I talked before. What we certainly will need is other workforce. We need new competences, new skills, new roles. What people are doing today will probably not the thing that they will do tomorrow. And that's something we can discuss later on. And so the second thing what we probably will know, it will be incremental. So it will not be a change from one day to another day. So we have to learn day by day how to tackle these issues. So this is the future. And so quite important about the future, it's impossible to predict. And the reason it's impossible to predict is that we are making the future. The future is in our hands. So we are creating the future. And so in dealing with people, in dealing with reality, in dealing with populations, we try to build a future in the best way. And that's I think it's important to monitor and to have the data for. And so coming out of our study of the joint action, so these are some of these new skills what we probably will need. Some skills are more related to the workforce itself. It will be more disciplinary. One of the studies we were doing is looking to teams. So just to give you an example, people that are, if a patient is admitted to a hospital for example, coronary bypass surgery, it's quite intensive. That surgery takes the patient in the hospital for 5-6 days at this moment in time. So what we learned out these studies is when we count the number of people that were involved with one patient. So if you look from the patient perspective, and you ask the patient how many people were caring for you, how many people has access to your health record, because that's a quite important criteria. So when you count them, we have more than 100 people. And so probably behind these 100 people are another 100 people that the patient don't see. So 100 people working together. So it's requiring skills, because you have to lead this group of people. You have to, they know their role, and if they know the goals, they have to share responsibilities. It's not quite easy. So workforce itself, it will change, and so probably we'll have new roles. Second thing is about populations. So we have to take care of our patients in a different way, more in relation to lifestyle, more in relation to prevention, and I think it will take other roles of nurses, of doctors, and how we deal with these issues. And the third element is the healthcare services. So what we see, certainly in our country, is that healthcare is very fragmented. So you have primary care, you have hospital care, and so it's very difficult to communicate, it's very difficult to document. I think it's quite important to make the links. It's also make the links with prevention. It's also important with the new data coming out, the new technology, looking to genomic sequencing and so on. So it's really looking to this kind of competences, and also make a lot of effort in building the information, the use of information and the understanding of information coming out of these different sources. I think it will be a critical competence for a lot of people. So what we see is that health workforce of the future will be different than the health workforce we see today. And I think we have to build that, and we have to build from it from now. And we see it happening. We see it happening in a lot of strategies. And I put a few strategies over here. You have the strategy of the WHO, working on global strategy on workforce. We have the strategy of IC, and I put it here, Judith, especially for you. On human resources in health, what is quite important. We have the strategy of WHO Europe, who developed a strategy specific on nursing and midwifery. But it's a list of strategy that really taking these new roles into account and really try to prepare workforce into the next generation, into the next future. And what I see is that these new, that these strategies are really built on existing knowledge. So they are very evidence-based in what they are producing, and really are building on this knowledge in preparing the future. The only problem what I see, and this is a challenge, and that's the thing I want to discuss with you after we have the presentations, is that I see the strategies but not the data. And what I mean by the data is not the data in building the strategy, but the data in monitoring the strategy. So, because it will be incremental, and so it means that we are starting with our strategies and implementing, and we have to do the follow-up. We are now involved in the WHO strategy for Europe on strengthening nursing and midwifery. So looking to the data, so it's forcing on the numbers, staffing, qualification level. It's focusing on working environments. It's focusing on evidence-based care. And when I look to the strategies and the indicators, they are perfect. The only thing what is lacking is how will we know if these indicators are met, how a country is doing, how our institution is doing. I think that's the main challenge. And so that's a call. That's a call. To close, I just made one call, and we are talking about the future, and it's thinking about what we need to do. So this is what I found in business. It's what you find on the internet. This is how businesses try to monitor their strategies. So you see consumer confidence, employment trends, help wanted online. I don't know what it is, help wanted online. I don't have any idea. Leading economic index, measure of CEO confidence. And you see it goes up and it goes down. So going up and it going down means that it's monitoring constantly. And so based on what you see over here, they are adjusting their strategy. And that's the idea. What do we need to adjust our strategy? What data do we need to do that? So that's what I tried. I tried just to copy it. First thing is patient or client confidence in healthcare. I think it's an interesting, so we are doing it. We need some instruments for doing that. We're going to standardization. I think comparable data is quite important. Probably the next one, employment trends, I think we can use. Help wanted online, I translated or I changed in nurse confidence. How confident are nurses in the way they are employed, they are working in their environment. So what we learned from nurses in all our studies, what we have been doing is, and so when we are talking about working environment, the working environment is not about external environment. It's not by pay or salaries, it's not by kindergartens or something. The really thing that matters for nurses is, am I able to do my job properly? That's the most important thing. So if they find that they can do their job properly as a professional, then they are happy to stay, wherever. If their opinion is that they cannot do their job properly, they are looking for another job. That's what we learned from intention to leave, all these kind of measures. So confidence is maybe a quite important topic or indicator to follow up. Health value, It's an interesting one. Huh? How much value are we creating? I think we have to define value. Value for patients. What does healthcare means for patients and how we can translate it? And the last one I put over here is a measure of chief nurse executive or officer confidence is the employer of confidence. Huh? How confident are you that you are doing the right things, that you're installing the right measures and so on, that you people can work in a proper way? I think we need to measure some of these indicators, huh? To really monitor these policies. Huh? Not to build a policy, but to monitor the policy. Huh? That is my call. Huh? So when I'm talking about data, we need data, otherwise we just have our opinion, but we need some indicators that lead us the right way, and it will be incremental. It will not a big change overnight or something. So it's really monitoring it. What is it's quite important. Thank you.
So, good evening, everybody. Happy Nursing Week. I'm going to take us home. So we're going to talk about what's happening on the Canadian landscape in terms of data. And I'm just going to push that away. You're getting feedback? I'm the informatics person, but I have paper. So I didn't want to have to twist my neck. But anyways, what I wanted to do was just to give you a very fast run through about some of the initiatives that have been underway in Canada for actually the last couple of decades. And believe it or not, there's been a lot of work that's transpired in this province and beyond. And there's lots of very exciting initiatives that are starting to kick off. So, first of all, I'm just going to give you a very quick history tour. And I haven't captured every single... Oh, okay. Thank you. But I think what's important is to just understand a little bit about the journey that we've had in this country in terms of nursing data standards. And so we harken back to 1992 when there was a meeting held in Edmonton, Alberta, and some of us were at that meeting. I was actually there as a student, and Linda was there, and Mike Villeneuve was there, and Dot was there, and a number of other people. And this was really the first discussion that transpired relative to the development of some core standards to reflect nursing practice. And so what came out of that was something called health information nursing components. And it was simply client status rather than diagnosis, nursing interventions, nursing outcomes, and nursing intensity or nursing workload. Subsequent to that, the CNA actually endorsed the adoption of the International Classification of Nursing Practice. And if you're not familiar with it, I encourage you to go to the website. It's a very detailed terminology. There's lots and lots of information there. And then in the latter part of the 90s, under the leadership of Dr. Dorothy Pringle, our Dean Emeritus, we launched the HOBIC initiative here in Ontario, and I'll say a little bit more about that in a few minutes for those of you who may not be familiar. And that initiative actually just wrapped up in this past year in Ontario. But subsequent to that, we actually achieved some funding through CNA support with Canada Health Infoway, and we extended that to CHOBIC, which is a Canadian version, and extended to Manitoba and Saskatchewan, and even today are still in some additional discussions with other jurisdictions to extend the use of CHOBIC. And so the CHOBIC last phase wrapped up last year, the end of 2014, and was reported back to our funders in 2015. And at this point, there's no further funding available, but there was funding also channeled to support a national initiative around a nursing quality report. I don't know how many of you are familiar with either of these initiatives, but again, it was an effort to provide some standardized metrics for use by nurse execs primarily in looking at impact of things like staffing, incidence of outcomes around falls, and prevalence of certain other adverse events. And I'll show you a few examples in a second. So that actually was funded for a couple of years to test and see, is it feasible to collect this common set of 19 measures across the country? And there were a number of hospitals involved. And the net of this initiative was that we still have a tremendous amount of data gathering happening on paper. Surprise, surprise. That not everybody measures things the same way. Surprise, surprise. So how can we possibly compare? And so we actually, with the wrap-up of the CHOBIC, we started discussions with the Canadian Institute of Health Information, which is our national repository, where there actually is very minimal evidence that a nurse ever touched a patient in the system in this country. So there's a bit of data around the inter-RI tools from home care, mental health, and long-term care, but quite frankly, most of the data that gets abstracted into that data set from hospital discharges is very, very basic, and it's common metrics around morbidity, mortality, information about surgical procedures and the like. So I could go on and on. I could give you a whole day's lecture on this, so I'm going to stop. But we've also done some mapping work with CHOBIC to the ICMP so that we know that we have a correspondence there of the data that we're looking at in our data sets here. And there's a whole lot of other things happening in this space that I won't bore you with. But I think what's really important here is to recognize that we've started with a very small suite of patient outcomes, client outcomes, looking at common things that could be measured and captured in acute care, home care, long-term care, and complex continuing care. And in some instances, what's really important here is that we actually were able to get consensus, using home care as an example, getting 5 home care competitors in a room and get agreement on a standardized admission and discharge form. Imagine. And we actually did the same thing with 9 acute care hospitals in this province, got them to reach consensus on what should be in, what should be out. Because quite frankly, we still collect a lot of information and data that we never look at, that we never use, but we still have this need to hang on to it. So we need to collect things that are meaningful and that have value back to patients, to nurses, to the system. And so the NNQR, just give you a few examples of some of the measures. There's 19 in there, and they're basically segmented into structure, process, and outcome. And so there's 5 to 6 relative to each of those domains. And one of the things I'll also say is that there's been a fair amount of research done with the CHOBIC data here by some of our researchers in Bloomberg, but also in IHPME. And we're finding that there's some predictive relationship between the CHOBIC measures and readmission rates and things like length of stay and ALC. So we need comparable, shareable data to be able to make good decisions. And we need to consistently represent nursing in electronic health records. Now, I've been doing this work for 25 years of my career, and I can tell you what we have unfortunately embarked on as we've implemented EHRs is that we've been replicating our paper processes and our paper data. We haven't taken advantage of that as an opportunity to really come together and unify our approaches. And so these are really important steps to be taken if we're really going to be able to inform decisions around resources and impacts on patient care, and we want to be able to show nurses' contribution. This is a quote that came out of an op-ed that Kathleen McMillan had published on Friday in the Halifax Chronicle-Herald. Some of you will remember Kathleen was our chief nurse here in the province a few years back. She's now the dean at Dalhousie, and she responded to an op-ed and a paper that was published just a couple of weeks after a meeting that we had, and made a very good case for the reason we need to focus on outcomes and not just counting stuff. So the other thing I wanted to say is that we did have a meeting here just this past month with 60 leaders from across Canada, and we began the dialogue on how do we advance the adoption of a pan-Canadian core set of data standards. And so the outcomes of that meeting will be published in a proceedings imminently. I'm not sort of going to get into all the details, but we had a great meeting and lots of good outputs at the end of it. So the opportunities, I think we have some terrific opportunities here if we can get this right. And the time is now. There are many leverage points to be used. And I think the fact that we're actually putting forward a resolution to the CNA biennium on the adoption of a national set of nursing data standards that's been submitted and will be tabled in June. So that was kind of one of our big outputs. And this is the nursing informatics pin, just as an FYI, those of you familiar with the Rose diagram. And that is representative of our first nurse statistician, and so we've adopted this as our image for informatics in the country. The vision, quite simply, is really being able to aggregate data from the granular level right up to conceivably at some point internationally with the adoption of tools like ICMP. And so you can see illustrations of how we can sort of start to roll up data in a very meaningful way. If any of you are interested in this paper, Peggy White and I wrote it in preparation for the symposium, and I'm happy to share it with anybody interested. And I think the benefits are potentially profound, and I think they're obvious if we can get it right, and I think the time is now to work nationally on this, and so this is where we're actually going to have some very concrete action plans moving forward. We've already got a meeting scheduled for next year to revisit the work that we do in the coming months. And so I leave you with this, that who knows? Anything is possible, and I think consensus is possible, and I turn it over to Kelly. Thank you.
And what I'm talking about. So I'm going to change it up a bit. Definitely my focus in my research is on the clinical situation and patient-focused research. So I'm going to share with you my experience in talking to patients and trying to understand what their questions were in terms of their clinical questions and how that could translate into research and what it would take to be able to perform that type of research. So I'm just going to give you a little primer on what I do, just so you can understand the clinical context. When I first started in research, the 2 breast cancer genes had just been discovered. So what we were dealing with was that the basic scientists had discovered these genes, and we didn't know what to do with this information clinically. We didn't know what to tell our patients in terms of cancer prevention and cancer treatment. So what we knew from some of the early research was that these patients had a very high lifetime risk of developing both breast and ovarian cancer. So when we were counseling our patients, we were telling them that they had up to an 85% lifetime risk of breast cancer, up to a 40% lifetime risk of ovarian cancer. So what were we able to tell them in terms of what they could do with that risk? And that was the difficult situation that we were in when we were talking to some of our patients. Not only did they have very high risks of developing cancer, they also developed them at very young ages. So we're talking about women who are developing breast cancer in their 30s and their 40s, which is very different than what we would see in what we would call the sporadic breast cancers, where it's not due to a genetic mutation that's being passed down from generation to generation. So again, with these ages, there are different clinical issues that go along with that, taking in mind where these patients are in their lifetime. They're usually young, they have young children. How can we prevent cancers at an early age, or if they are diagnosed with breast cancer, how can we ensure or try to maximize their chance of surviving because they still have a lot of years ahead of them? So the ultimate goal when we're thinking about genetic testing for the breast cancer genes is that we want to reduce the chance that these women will die of breast cancer. And that's in the form of both prevention and the form of treatment. So if you can remember back to your high school biology days when we all learned how to do a family history, and this is something that I really push for in terms of nurses knowing how to take a family history, this is something that affects all diseases. We all need to understand what's happening within not only our own family histories, but also in our patients. So this would be the typical kind of family that we would see. And you can see here, these are the patients that we're seeing in our clinic. So if they're not shaded in, that means they don't have cancer. If they are shaded in, it does mean they have cancer. So you can see the young ages of breast cancer diagnosis. So the question from these patients that we were seeing is, what should I do to treat my breast cancer so I can try to survive this disease? And for the patients who were not affected with cancer, it was, what can I do to prevent myself from developing breast cancer in the future. And that's really what I've devoted my research career to, is to trying to understand this. And by understanding it, trying to translate it back to the patients, so ultimately it will be the patients that benefit from this research. The problem back when I started this research was we had very little data. So to be able to answer these questions was going to be a difficult undertaking with the data that we had available to us. So I set out to try and answer some of these questions, and it really was being able to develop a database. So the one question I'm going to focus on in today's talk was the question that these patients were presenting, that if I have breast cancer and I have a BRCA mutation, should I have the same type of treatment that a woman with sporadic breast cancer would have, which typically is a lumpectomy and radiation. We weren't sure that that would actually be the most effective for patients with this different type of breast cancer. But there were several issues, like I said. We had no data. So there was no detailed database where we would be able to answer this type of question. We needed a large sample to be able to answer this question, and the issue in this clinical area is that only 10% of women with breast cancer have a BRCA1 or 2 mutation. So being able to collect this large amount of data was going to take a lot of collaborations with people throughout North America. So we were able to establish those collaborations and start to collect this data, because it really was a question for interest to clinicians that were treating these patients all over the world, as well as patients who were being seen in our clinics. The other issues that I struggled with, because I knew my primary outcome was going to be mortality, was that we couldn't just include women who had survived their breast cancer, those patients that we were seeing in our clinics. We also had to systematically go through all of the families and try and collect information on the living relatives with breast cancer, as well as the deceased cases, so that we would reduce our chance of survivorship bias. So again, this was a big issue in trying to create this database to answer this very important question. So a North American database was created, and I have been collecting this data for over 15 years now. We continue to follow these patients every 2 years. And we have come out with excellent, in my opinion, research, and I think it's guiding practice all over the world. So this was a multi-center cohort study. We were collecting everything on their family history and all of their pathology and all of their clinical information, and we continue to follow these patients every 2 years. So what was the end result in all of this? It wasn't like I could just go to ISIS and pull this data and be able to answer these research questions. It really was having to establish this database to answer these research questions. We now have the largest known database of its kind in the world, and as a result, many researchers are able to access this data to answer questions that are important to them. And we all come from very different backgrounds, and so we all have very different research questions, so people can do that. We were very fortunate in this patient population that they were also very committed to this research, because they knew it was not only going to affect themselves, but their relatives as well, because this really is a family type of situation that we're dealing with, because these genetic mutations are passed down from generation to generation. We have complete pathological treatment and follow-up data. We have over 12 years of average follow-up time on these patients, so we can look not only at short-term outcomes, but at very long-term outcomes as well. And I think we've really created a legacy in that we have established this database that we can continue to ask research questions, and many other investigators can as well. So what did we learn from this study? Because I set out to try and understand how we can help women to make decisions about their treatment. Well, first of all, we had to know what the right treatment was. And what we have shown and published a lot on is that these women have not only a high chance of a first breast cancer, but they have a very high lifetime risk of developing a subsequent breast cancer. So that all has to go into their understanding of what kind of treatment decisions to make. We showed that these women, by having both breasts removed at the time of breast cancer diagnosis, could reduce their chance of dying by half. So we can't say very much about these kind of numbers in terms of reducing your chance of mortality for very many treatments in cancer. So to be able to say this definitely changed our understanding of this type of cancer. And also an oophorectomy, which is the removal of the ovaries, also reduced the risk of dying by about half. So then the question became, okay, we know this, so what are we going to do with this data to change patient care and to help women make decisions about their care? So we're thinking about changes to policy, we're thinking about changes to practice and patient decision making. And that was really a commitment of mine, that this wasn't going to be research from this data that we collected to sit on the shelf somewhere, but we really wanted to be able to take it back to the patient. So we know from this data that we collected that treatment should be personalized for women with a BRCA mutation. We can decrease mortality, but the question was, if women knew they had a genetic mutation at the time of breast cancer diagnosis, would they change their treatments? And that was something that I was very interested in. And I also was interested in, if we offer genetic testing at the time of breast cancer diagnosis, are we going to be causing additional distress than they're already experiencing? So thinking about the policy for genetic testing in the province, and it's very similar across Canada. Typically, a woman has to meet criteria for testing. Testing takes a long time, 3 to 6 months. It can be expedited, but that generally takes about 6 weeks. But we know within the province that less than 13% of all of the tests that were ordered are expedited. The issue then was that most women do not know if they have a genetic mutation at the time of their breast cancer diagnosis. So how can they make decisions if they don't have that kind of information? So I wanted to change that, and based on the information that we gained from that study where we collected all of the data, I wanted to know that if we could provide genetic testing at the time of breast cancer diagnosis before a woman made her decisions, could we change her decision making? So we were funded by CIHR to look at this. I was interested in some of the psychosocial issues that went along with it, the satisfaction with the delivery of this type of care. So we were funded to do rapid genetic testing on 1,000 women at the time of breast cancer diagnosis. So we gave these women their genetic test results within 10 days before they made their surgical decisions. We're halfway through. We've tested just over 500 women. And of those women, most of the women changed their surgery choice. 76% of these women went on to have a bilateral mastectomy, so showing that if we could provide this information, we were having an impact on patient decision making. In terms of distress, you can see that because that's something I'm very interested in, we weren't causing extra distress. Those who were negative had the same amount of distress as those who were positive. So what was the impact of creating a database? We now have a lot more information about what the cancer risks are for women after they're diagnosed with an initial diagnosis of breast cancer. We know what the best treatments are for these women to increase their chance of survival. We've influenced the guidelines for the provision of care for these patients. So now all women who know that they have a BRCA mutation at the time of breast cancer diagnosis are counseled to have a bilateral mastectomy. We were able to take that research and translate it into developing a grant to translate these research findings into clinical practice. And we're showing that if we can provide this type of information at the time of breast cancer diagnosis, we can have an influence on patient decision making. And we're also being able, with this information, because we're testing women, we're able to determine whether or not we need to change our policy for genetic testing within the province. So I think we all have clinical ideas, and some of us who work in the clinical practice, we have a clinical idea. It often is going to take a lot of collaboration and perseverance to be able to establish this type of data to answer these big research questions. So that's where I'd like to end, and I'll sit down and we'll take the questions.
So thank you very much to all of our panel members. So we saw data and the use of data from 3 totally different perspectives. So more at a very high level policy, and Lynn talking more about how administrators and executives, nurse leaders can use data related to decision making around healthcare and nursing care. And then Kelly is an example of a researcher having a question and developing a database to actually study that over time and build on it and help patients make decisions. So it's a really interesting groupings of the use of data and how data can inform policy, administrative decision-making, and clinical practice. So open it up for questions to anybody in the audience. Anybody have any comments or questions? Dave would like me to remind everyone to use the microphones, please. Okay.
If I may direct a question for Kelly, please. Do you see your database as being able to be linked to other databases? I'm thinking, for example, the glomerular nephritis database that Dr. Catran has at Toronto General Hospital.
Yes. The issue with this database is that it's North American wide, so it would be very difficult to link to any administrative type of databases because the majority of patients are not from a specific province. It's probably half the participants are from the US, maybe even more than half, and the rest are from Canada. So it would be very difficult, but I am very committed to continuing to follow this patient population. And because I do think that this is a different kind of breast cancer, and we're going to see very late events compared to patients where we usually follow for 5 years and we say your 5-year survival rate is this. So it is because they have such a high risk of developing new cancers.
Okay.
You're welcome.
Any other questions? Yes, come on up to the microphone, please. Dot, of course.
Yes. I'm impressed.
Because I've worked on HOBIC for a long time and influenced by Lynn, I know that in the absence of patient outcomes and data on patient outcomes, it's hard for us to go back and assess a lot of issues around quality and efficiency and things like patient staffing. Like, we don't know that unless we know the impact on patient outcomes. So I'm interested in the work that you reported on, Dr. Sermius, around what kind of patient outcomes are involved in that and how many would be relevant to being able to assess the kind of quality input from nursing.
Thank you for the question. I think it's a very important question. So we did some work in our big European study. So we did work together with Dr. Lynn Aiken from the University of Pennsylvania. We have a large database on staffing data in Europe. Together we combined it with other databases. So the data, we have about 30,000 nurses surveyed about their working conditions, what is quite large, about 500 hospitals in Europe. And we connected these data with patient electronic or hospital discharge data. So it's our patient abstracts of patient records. And I think it's important to link these databases. Huh? And so I can tell you it's not easy to do, to make the link, because you have different identifiers and we have privacy laws, and so it's making things complicated, but it's important to do. So that's what we were able to do, is to link the staffing data of hospitals with hospital discharge data from these patients. And so we have also data about patient satisfaction. So one of the elements we took into account was mortality, in hospital mortality. It's also not an easy indicator, because mortality, it's linked to many things. People are dying because they have some genetic disorder or because they are older, and there are lot of risk factors. So it's building on complex models. What we were doing was looking to surgical care, elective surgery, and routine surgery. So it means that you take a lot of causes away and really looking to what is the impact of organization on mortality. So that's what we were taking into account. And so what we found was a large difference in mortality rates in European hospitals. To give you an idea about the difference, in some hospitals for this routine surgery, we are talking about orthopedics, general surgery, so routine small surgery. It went from 0% in some hospitals up to 7% in other hospitals. It's an immense variability. The variability, it's not only between countries. The main variability is within a country. So for my country, Belgium, we saw some data about 0.25% of mortality up to more than 3%. So again, a difference of 15 times, 20 times higher of mortality. And then we take all the patient characteristics into account. So we are adjusting for age, we are adjusting for comorbidities and so on. And then we see that there's some staffing effect left, as well as for the numbers of people, as well as for qualification levels. And that's the connection. So I think mortality is a very crude indicator, but I think it's the most important indicator. So you really have this mortality under control. And so just for routine surgery, the population expectation for dying from routine surgery is not existing. So the risk in their perspective is 0%. So on average we have 1% of risk, but it's 0% from their perspective. And I think we have to create the conditions to make it as safe as possible. And I think that's a challenge. I think there are some other some other elements. We see many indicators that are quite sensitive to staffing. It's on adverse events, it's on infection rates, it's on falls, it's on pressure sores. There is a list of adverse events, that's what we see. And there are also some positive indicators. And positive indicators is rehabilitation, functional state is what patients can do. It's about information and education. So we have some positive and negative factors. But I think the list of factors, it's very large. Of course, it cannot only be contributed to staffing, because care is interdisciplinary, it's teamwork and so on. But what we see, staffing is still a quite important factor in explaining a lot of the differences. But I agree, we need this outcome data to really adjust the way we are organized. So if you don't have these kind of data, it makes no use to discuss on staffing ratios.
Okay, thank you. Somebody else had a question that was there? You want to pop up to the microphone, and then you go next, Alex. Go ahead.
Hi, I just wanted to ask, with the importance of mortality as maybe the most important data, what other data should we be looking to collect in order to try to optimize our healthcare system? Because as we all know, that we are sort of at a base freeze, so how do we empower all levels of the healthcare team to work to their maximum scope and try to make the most of the resources we have? What sort of data indicators should we be looking forward, and at what point can we say research from Europe is something that we can apply here, or should we be looking at our own data, and how long will it take us to collect that before we can utilize it with our aging population? I think the need for resources is going to be sooner than later, and just want to make sure we can get the data and use it before we sort of miss our window. Thank you.
Thank you for your question. I think that we have highlighted what some of those outcome measures should be, and a lot of the HOBIC work was, well, it was all derived on the basis of evidence that we have that show nurses make a difference in terms of these outcomes. So we started with a small suite of metrics. They're evidence-based. We know that there's predictive capability there based on the research of Leanne Jeffs and Winnie Sun and a few other people, Walter Wochus. We've got some good preliminary indication that these are very predictive and could be quite useful. But quite frankly, we're still looking at a small constituency of the overall healthcare system whereby those are being captured in a consistent manner. So I think that's still, in my view, a place to start. There's probably lots of other things that we could add, but I think we've got that piece right, and we can continue to move that forward.
Okay, thank you. Alex?
Hi, I had a question for all the panelists, actually. So I guess when we talk about data in a room full of data-driven or research-oriented folks, it's an easy case to be made. But I'm curious for when I look at the presentation and the title, decision-making, we know that decision makers and uptake and use of data is a very different situation than it is than we would like, I guess. And so I'm wondering, from your own perspective and experience, what do you think the factors are that have both impeded and helped the uptake and use of data on the decision-making end of things?
Question to end the panel discussion with. I'm just sensitive of the time, so I'm going to give each of you the opportunity to respond to that, and then we'll close for the evening.
I can start. I think it's a great question. And we are aware that decision is not only made on evidence. So it's sometimes we are talking about evidence-based decision making. It's not true. It's evidence-informed decision making. So you are taking the evidence into account. But of course, it has to do not only with the evidence and the data, but it has also to do with the values and what you think is important, and it has to do with situations. And I see sometimes our stakes are also in place, and so you're defending your position because sometimes it's about your living and so on. So it's what I see. It's more complicated. The only thing what I see is that data and evidence can help. Otherwise, it's opinions against opinions. And so what I see is data are helping to make a distinction between subjective and objective, and it's helping the process of decision making. But the process is a little bit more complicated, I agree.
That's a great question, Alex, but I think, quite honestly, there's still a lot of the whole sentiment that we haven't got good data yet, and we have to wait till we have better data, and we can keep waiting and waiting. It's like waiting for the water to run cold in the desert. And I think we need to get on with it, because only by using it will we improve it. But I think that has been an impediment, and people will always try and poke holes in the evidence that you're bringing forward. And if it is evidence-based, then I think, to Walter's point, informed decisions is also another shift that needs to happen in the whole culture of care. And that starts at the bedside right up through to the leadership, or vice versa, if you want to go the other way. But we don't have a culture of using information and data in the way that we could be. And I think we need to make some shifts there.
And I'll just build on that, because you did mention the informed decision. And I think, thinking from the patient's perspective, because that's how my research is focused, that's been very important to me too. And I think getting that information to the patient, and a lot of my research is focused on developing decision aids for these patients to try and make these very difficult decisions. And it's not just about educating them, it's also taking into account their values and beliefs, and how no decision is right for any person, two people. There are going to be many different factors that contribute to that decision, and we have to be respectable of that, or we have to respect that in when we're thinking about our patients.
So I want to take this opportunity to thank the panel for their presentations this evening, and for all of you for attending and coming out for our event this evening, this Nursing Week. I'm sure if you have any questions, you can pop up to the front. I'm just sensitive that people have lives to get back to this evening, so I just want to thank you again for coming, and happy Nursing Week.